All right, and so it looks like it's just us for this one today, but we'll go ahead and record it and then we can put it up on your YouTube channel as well. So for anybody that's watching this from home or that may be watching it right now, we are going to be talking today about steroid treatments in COVID patients and trying to get some recommendations for what the correct use of steroids are going to be in this patient population. So there was an article that was released. It was released about 9 days ago. And it tried to give some advice on what to do with steroids in these patients. So this article, corticosteroid treatment for patients with coronavirus disease, again, was published about 9 days ago. And for the background, for those of you that have been tuning in every week, it's going to be pretty similar, just as we've gone over the characteristics of coronavirus pretty in detail at this point. But for anybody that is just tuning in this time, I'll go over a few of the highlights real quick. So viral characteristics of the coronavirus. This is a positive sense single-stranded RNA virus. Through the viral replication, it does not actually carry any viral enzymes in the capsid itself. And so everything is done through the cellular proteins. Because it doesn't have anything that it carries with it, it makes it very difficult to find a drug therapy that is going to be selective for a single-stranded RNA virus. The mortality for coronavirus ranges anywhere from less than 1% to about 27%. This really varies depending on the age of the patient and then also location. And so some mortality differences have been seen between China and the United States. And so it really depends on where you get infected as well. In some reports, patients with severe disease, so especially those ventilated, can have a mortality rate as high as 78%. Viral shedding, or the contagious period for this virus, becomes active about 2 to 3 days before the symptom onset of the virus. And this virus can live on some surfaces like plastics for up to 72 hours. So the combination of people not knowing that they are infected and the long survival rate of this virus on some surfaces is what has led to the high contractibility of the virus and then widespread infection in the pandemic that we're in currently. As of this morning, when I checked, there were over 2 million cases that were confirmed worldwide with over 150,000 deaths. In New York alone, there have been over 10,000 fatalities. Compared to the numbers from last week, it does appear that the new cases that we're seeing every day seem to be slowing down in some portions of New York. But it should be pointed out, I think that in New York, we have not hit the peak of infection yet, and our curve still is rising. So for the coronavirus disease, many patients are going to be asymptomatic or have a mild form, showing only upper respiratory tract infections, so like a pharyngitis in presentation. When patients have more severe disease, this often includes shortness of breath, dry cough, symptoms more indicative of a pneumonia, so like opacities on a chest x-ray. These patients also may show lab abnormalities like an increased D-dimer, ESR, PT interval, and ferritin on the laboratory findings. Many institutions have developed protocols for things such as anticoagulation in these patients, but the little nuances of COVID-19 and the little things that we are seeing as we treat this disease have led to really continued questions about what is appropriate in the therapy for these patients. Patients with severe disease often develop ARDS or a cytokine storm, and this is going to contribute to the breakdown of the alveolar sacs in the lungs, preventing oxygenation. So I mentioned ARDS, and ARDS is important for steroid therapy. Acute respiratory distress syndrome is defined as the onset of respiratory failure due to trauma, inflammation, or again, in this case, a severe infection. The development of ARDS has significant morbidity and mortality associated with it and can be classified through the Berlin criteria with the PaO2-FiO2 ratio. If that number is between 2 to 300, that classifies as mild ARDS. If it's 1 to 200, that classifies as moderate ARDS. And if it is under 100, then that classifies as severe disease. ARDS typically is going to be treated through a combination of oxygen therapy, IV fluids, and then addressing the main cause of why the patient is in respiratory failure. So steroid medications are going to interact in a wide variety of ways in our body. They act by regulating our body's gene expression. So they bind to intracellular receptors, and then that's when they're brought into the nucleus where they can have that effect on our gene regulation. Corticosteroids have influences on so many different systems within our body. So the cardiovascular system, immune system, musculoskeletal system, endocrine system, and the nervous system, just to name a few. In reference to ARDS, where we see corticosteroids wanting to be used in our patients with COVID-19, the mechanism is thought through a reduction in inflammation that can be contributing to a decrease in oxygenation. So corticosteroids are going to decrease inflammation, and this occurs through helping suppress leukocyte migration and reversing capillary permeability. So before we jump into the actual article that was published about a week ago, I think for steroids specifically, it's really important that we have an idea of some of the past literature that has been done on this subject before. And so I've separated in my review here as literature that supports the use of steroids versus literature against the use of steroids. And as you can see, there are quite a few articles, both supporting and against the use of steroids. And so when we're looking at articles that support the use of steroids, we're looking at mainly articles that are addressing corticosteroid use in acute respiratory distress syndrome. And so I've tried to highlight or underline here kind of the main outcome of every study. And so this first study looked at corticosteroids in acute respiratory distress syndrome. It was a meta-analysis and found a reduced all-cause mortality and a reduced duration of mechanical ventilation in ARDS. The next study was dexamethasone specifically in acute respiratory distress syndrome, but they also found an increase in the number of ventilator-free days and a reduction in mortality at 60 days. Another study looked at the effects of corticotherapy in early ARDS, and this did not find a benefit necessarily with the corticosteroids, but they did find that corticosteroid therapy was not associated with a higher mortality. So they just found that there was no difference there. And thank you, Dr. Waldeck, for sending me an article actually last night. This last one that I found is actually a commentary that the Society for Critical Care Medicine sent out in an email. And it's a commentary on the rationale for giving corticosteroids in patients specifically with COVID-19. So it's not a study per se, but it does give a rationale for why we should be using steroids in these patients. And so it is still really debated whether these therapies are going to be used in our COVID patients. Some of the literature that we have against the use of steroids, the first three here actually are articles for use in acute respiratory distress syndrome or on mortality for patients with influenza pneumonia. Now, influenza pneumonia and coronavirus pneumonia are not the exact same, but influenza is a viral pneumonia, and it is a single-strand RNA virus pneumonia to add to that as well. And so the use of corticosteroids in influenza-induced acute respiratory distress syndrome. This study was a meta-analysis of observational studies found an increase in mortality with these patients. With influenza pneumonia, the second study found an increase in mortality, ICU length of stay, and a rate of secondary infections. And then just for an influenza virus, another meta-analysis found that there was a significant increase in mortality, duration of mechanical ventilation, and the duration of the ICU stay. Some of the other studies that I found, this next study was looking at the effects of corticosteroid treatment on plasma concentrations, plasma viral concentrations. This did not look at the current coronavirus, but was actually looking at the SARS from 2002. Now the SARS from 2002 and the SARS that we currently do have are about 70% related genetically. So there are quite a bit of similarities between those viruses. In this study, they treated with hydrocortisone 100 milligrams IV every 8 hours within 7 days of the illness onset. They found that when they gave the corticosteroids, viral concentrations in the second and third weeks post-illness were significantly higher in patients who had received hydrocortisone, and it was hypothesized that this is going to lengthen the duration of treatment that was necessary for these patients. And then lastly, this is more of an observation study. It was a clinical course and risk factors for mortality of adult patients, and this came from Wuhan, China, the epicenter of the disease in China. And so it's a retrospective cohort that showed a mortality of 48% in patients that received corticosteroids versus 23% in people that did not receive corticosteroids. Now, this was a retrospective study, and so this data should be taken with a grain of salt because those patients that were receiving steroids may have just been sicker patients. And so it's hard to look at that data and find too much out of it, but it is something that was published fairly recently as an observation. So why this study? As you can see, there are quite a bit of studies that have been published in the past that recommend treatment with corticosteroids or without corticosteroids for COVID-19 patients. The articles that are recommending corticosteroids in the treatment of COVID-19 are recommending it based on articles in the treatment of ARDS, or acute respiratory distress syndrome, which our COVID-19 patients do develop. But there is a lot of past data on the use of corticosteroids in the 2002 SARS and the 2012 MERS outbreaks. And this data actually conflicts with the ARDS data and says that we should not be using corticosteroids. So this is where the root of the problem comes from. There are simply so many articles with conflicting ideas that it's really unclear what we should be doing in our COVID-19 patients. So the objective of this study was really to report the impact of corticosteroid therapies in their COVID-19 patients. I think it's really important in this study, they weren't actually hoping to find an answer about what they should do with steroids. They just wanted to gain more information to hopefully design a randomized control trial somewhere in the future. All these patients were from Anhui, China, and this was an observational cohort study. So patients were recruited from 2 different sites in Anhui, Wuhu, China, the Second People's Hospital of Wuhu and the Yijichuan Hospital, again in Anhui, China. So these are the only 2 hospitals that COVID patients are allowed to be admitted to in this province of China. These hospitals, a lot of the data that's coming out of China are coming from these 2 hospitals. I hadn't realized before that they are the only hospitals that COVID-19 patients are allowed to be admitted to. Inclusion criteria was hospital admission between January 24th and February 24th, and a confirmed infection through PCR through their local Center for Disease Control. The standard of care that was used in these patients was lopinavir and ritonavir plus interferon alpha. In some patients, because this was an observational retrospective study, did receive umifenavir, and some patients did receive moxifloxacin. Umifenavir specifically is a medication that we don't see in the United States. It blocks viral endocytosis for a large array of viruses, and it is approved in Russia and China to be used in the influenza vaccine. And so they have been using it for COVID, though I have not seen any data to say umifenavir definitively does work in COVID patients either. And moxifloxacin is not an antibiotic we see with a lot of common, or very commonly here in the United States, but they were also using moxifloxacin for bacterial prophylaxis. This was used in about 14 patients. So the intervention that they did use in this study was methylprednisolone, 40 milligrams every day or twice daily. And so they left it up to the physician how often they did want to use that, but they did use methylprednisolone in all their patients. So data was collected for the patients in a retrospective fashion by going through the chart. Demographics such as age, sex, and comorbidity were recorded. Clinical conditions of presentation and the time from symptom onset to admission. Clinical conditions, they really were just recording their symptoms at the onset and how they were presenting to the hospital. Laboratory and vital sign recordings were, again, recorded for this study. They looked at radiological findings, treatments, viral clearance, and clinical outcomes. Clinical outcomes aren't defined super clearly, but we'll get into that in a second here. The primary outcome from this study was the time to viral clearance as confirmed by a PCR in the throat sample. Viral clearance, again, was defined as having 2 consecutive negative PCR results that were at least 24 hours apart. And they calculated this as the time from the onset to the time of the first negative PCR result. Secondary outcomes included the duration of clinical recovery. Again, the clinical outcome or clinical recovery was not super well defined, and it was somewhat subjective in this study. It was really defined as, or determined just by the attending physician. They didn't have any definitions to clearly define that. They just left it up to the physician what that meant. And then another secondary outcome was the length of hospital stay. Statistical analyses. Most of the variables in this study were recorded as simple descriptive statistics. Continuous variables were going to be the median values with an interquartile range, and then categorical variables are presented as percentages. There were some comparisons made between those patients that received corticosteroids and those that did not receive corticosteroids. So the Fisher exact test and Wilcoxon sign rank test were used to look at the categorical variables. And then the Mann-Whitney U test was used for continuous variables and their statistical analyses. Survival analysis was also used to evaluate the corticosteroid therapy impact on time to study outcomes. And survival analysis is used more often when we want to analyze an expected duration of time for something. The enrollment, a total of 31 patients were included in this study in the end. And the majority of these patients did have a history of travel to Wuhan, China. Wuhan, China, again, is that epicenter where the coronavirus outbreak did begin in China. So looking at the baseline characteristics here, again, there were 31 patients. The average age was about 40 years old, though there was some difference between non-corticosteroid and corticosteroid treatment groups. This difference was not significant, though. A majority of the patients were male. And then the next thing I'd like to look at is how these patients presented to the hospital. I think it's really important to look at these three signs and symptoms here. So we have our temperature, a presence of cough, and the presence of fatigue. If you look here in the non-corticosteroid group, a smaller percentage of these patients did have cough, a smaller percentage had fatigue, and they did not have as high of temperatures. In the corticosteroid group, these patients tended to have higher temperatures. 100% of them did have a cough, and then 91% of them did have fatigue. So what this tells me as a group was that the patients that received corticosteroids likely were the sicker patients in this study that were receiving that therapy. Because this was a retrospective analysis, this does make sense somewhat, that those sicker patients were going to be needing additional therapies. The next thing I'd like to look at is the respiratory rate and the O2 saturations. And I don't have these highlighted, I apologize for that. But if you look between both groups, there's no statistical difference. The respiratory rate was about 20 in these patients, so not super high. And the O2 saturation on admission was 98%. And so these patients really were not super sick. They weren't the patients that were satting below 93% that you may need to get on supplemental oxygen. These patients really weren't requiring a lot of these additional therapies. I'd also like to point out a difference in CRP between the patients. The average was 23.2, but between corticosteroid and non-corticosteroid patients, our corticosteroid group had a CRP of about 84, and the non-corticosteroid had a CRP of about 18.7. Again, there was a difference between radiological findings on admission between the two groups. So when looking at bilateral involvement on a chest CT, 100% of the patients in the corticosteroid group versus 45% of the patients in the non-corticosteroid group did have that bilateral involvement. So these two factors here really play into the same thing that we had talked about when looking at their signs and symptoms on admission. That the patients in the corticosteroid group were sicker patients than those in the non-corticosteroid patient population. So the next thing that we'd like to look at is the endpoints of the study and how they evaluated the results. The first thing they recorded were what treatments every patient was given. And so looking at the percentage of patients that received antibiotics, again, we see that the corticosteroid group of patients did receive more antibiotics overall than the patients in the non-corticosteroid group. Again, looking at lopinavir, ritonavir, and interferon, more patients in the corticosteroid group did receive those therapies. And then we did see more patients in the non-corticosteroid group receive a combination of umifenavir, lopinavir, ritonavir, and interferon alpha. When looking at the outcomes, we didn't see anybody pass away in this study, and there wasn't a statistical difference in the percentage of people that recovered from the virus either. In fact, when they looked at their analyses, there were no statistical differences between the corticosteroid and the non-corticosteroid groups. The average time to viral clearance was about 14 days. The duration of symptom was about 7 days, and the length of hospital stay was about 19 days. 84% recovered by the end of their study, and most of them had discharged from the hospital. There were only 5 patients that were not discharged from the hospital at the end of the study. In their survival analysis, the time to viral clearance had a hazard ratio of 1.26 with a p-value of 0.55, and time to discharge p-value of 0.54, and time to clinical resolution of a p-value of 0.7. So none of these were significant between non-corticosteroid and corticosteroid groups. The time to viral clearance did not change, as well as the time to clinical resolution of symptoms and discharge. Some of the study limitations that the authors do mention, though, the sample size of 31 really doesn't allow them to have firm conclusions about the use of these medications. And something that I alluded to in their baseline characteristics, this was a pretty young patient population, and all of them did have mild disease. So it really limits the generalizability of this study to other populations, especially populations that may be much more sick, needing ventilation, where we may see steroids used more frequently. And then again, the observational nature of this study does allow for confounding factors to influence the results of this study. So in conclusion, the authors concluded that the outcomes were overall good in this study, and there were no outcomes that were statistically associated with any of the two therapies, or the lack thereof. So they like to continue gathering data in their patient populations, and then recommend a formal randomized controlled trial somewhere in the future, to be able to formally evaluate the use of steroids in these patients. Some of the things that I pointed out when I was going through this study, the total population sample size was only 31 patients. And we mentioned that before, and I talked about this in one of the previous journal clubs, but in a statistical analysis, a higher population sample size is really going to lead to a greater power in a given study. So if you increase the power of the study, we can say more certainly that a given intervention is or is not effective. And so with a sample size of only 31 patients, it makes it very hard to generalize the study and again, make those firm conclusions about what you saw taking place there in the study. The study is also slightly underpowered for its size. And so even though the study did not mention any of their power calculations in their actual publication, I tried to, or I calculated their power myself. And given an alpha of 0.5 and an estimated power of 80% for their statistical analyses, they would need roughly a sample size of about 600 patients. Now, the statistical analyses for this patient population when using survival analysis is a little bit more complicated than typical power calculations. And so I am not a statistician, but when you plug in any of the numbers, it results in a sample size required of about 500 to 600 patients, which is much less than they did have. And so it's really hard to take any of the data and the statistical calculations very seriously after looking at this study. This study is also a retrospective observational study that evaluated differences in corticosteroid outcomes in patients. Again, as this was an observational study, there was no protocol that was in place for the patients enrolled. So in a typical controlled study, we're going to have a control, a placebo, and then a protocol that would be present. This is to ensure that any differences seen between the study group and the control are due to the intervention itself. But because there was no protocol in place here, there were confounding factors that may have added to or taken away from some of the results that we see. So one of the examples that I see in this study is that there was a standard of care they did use in their patients, but even that standard of care was not the same. Some patients did receive umifenivir, and in fact, a higher percentage of the patients that did receive umifenivir actually ended up being in the non-corticosteroid arm of the study. And so because the treatments weren't the same except for the study drug between patients, it's pretty hard to make conclusions based on any of the results you do see. In the primary outcome, the viral clearance results are defined as having 2 negative PCR samples taken at least 24 hours apart. So I also mentioned in the previous journal club, the journal club on hydroxychloroquine that we did on week 1. These PCR results are not simply given out as positive or negative. They're recorded as the number of cycles that the PCRs ran, and that determines the level of virus that they have in that sample. So after a certain number of cycles, they will deem the sample to be negative at that point. Or if the cycle has to be ran more times before something comes up, then they'll deem that as negative. This study did not release the number of cycles that had to be run for their viral patients. And although that may or may not take away from the study, I think it would have been very interesting to see how sick these patients were and be able to compare that data to the outside studies, just to get an idea again, of how mild this illness was versus the degree of viral sickness that these patients did have. And then as we can see in the results, the patients in this study, this would be one of the main limitations, were afflicted with a mild disease of COVID-19. So throughout the duration of the study, actually 0 of the 31 enrolled patients did develop ARDS. As we see in our patients here at Stony Brook, ARDS plays a critical role in the pathogenesis of COVID-19 and is very important for morbidity and mortality when they do require ventilation in the ICU. And so it's very difficult to be able to relay these results to our patients here at Stony Brook because our patients tend to be so much sicker than the patients that were in this study. Again, the non-development, I guess I should say, of any patients with ARDS in this study, I think it makes it very hard to generalize to our population and is one of the bigger limitations with this study. It would have been nice to see the corticosteroid use in patients that had developed ARDS or in patients that were a little bit sicker requiring ventilation as well. With that being said, I think in conclusion for this study, there is some good data pointing to the fact that the corticosteroids may not actually be increasing the time to viral shedding for this virus. But it would be interesting to see this data in a patient population that is more similar to ours. And so I think that at this point, it would be important just to play it on a case-by-case basis. There isn't a lot of data out there to support the use of steroids in these patients as a definitive treatment. And so I think if the patient needs it for their ARDS, it would be beneficial to use. But if they are not requiring it for ARDS or hypoxia, then it may be something that we can hold off until a later time. Anticipated literature, and so this is something, because this study was not great, it did not give us a lot of information about our patient population here at Stony Brook. I wanted to bring up some anticipated literature and look at some of the articles that are going to be coming out in the near future. And so there are 3 articles, 3 clinical trials in the clinicaltrials.gov that are ongoing at this point. One study is looking at the use of prednisone in patients. One study is looking at dexamethasone in ARDS specifically. And then one study is looking at methylprednisolone, again, in severe acute respiratory distress syndrome. And so it'll be really nice when these studies do come out. There were more than these 3 studies on the clinicaltrials.gov, but unfortunately, some of the studies are redacted or suspended. I looked into one of the suspended studies, and that's because China does not appear to be having as many patients anymore, and so they don't think that they'll be able to recruit enough patients at this time. But it will be interesting when these studies do come out. Most of them have already started recruitment, so hopefully we'll get some preliminary data fairly soon here. All right, and that is the end of this journal club. If anybody has any questions, please feel free to unmute yourself, and I can answer anything for you at this time. All right, and if there are no questions at this time, again, this will be recorded and then we can upload it to the YouTube website. For anybody that is watching this from home, please feel free to email me with any questions. I'd be happy to get back to you as soon as I get them. My email is tyler.maxwell@stonybrookmedicine.edu. Sorry about that. Feel free to email me with any questions. I'd be happy to get back to you whenever I can.